Well, thanks, Jay. I'll just share my my screen. Hopefully you can see the slides okay. Oh,
Yep.
I'm not back at the beginning. Hang on a second.
Yeah, we can see. Thank you.
You can, right. Okay, so I'm Mark Strachan. I'm an endocrinologist in Edinburgh. In fact, I'm actually speaking to you from the Royal College of Physicians of Edinburgh, because I'm here for another meeting. So I'm going to speak briefly about TSH suppression. I'm conscious of the time, so I'll try and rattle through this. So the first thing to say is that TSH suppression in differentiated thyroid cancer makes total logical sense. TSH, when it binds to the TSH receptor in thyroid cells, causes a whole variety of intracellular effects, many of them related to, of course, the synthesis of thyroid hormone. But TSH also stimulates a whole variety of intracellular changes that lead to the increase in the size and the number of thyroid epithelial cells. And so the logic of TSH suppression in differentiated thyroid cancer is robust. The problem is that the evidence base is actually not as strong as we might imagine it would be. So here are, this is a meta-analysis of a variety of studies that have looked at outcomes in studies in patients who have or have not had TSH suppression. Now, the first thing you'll see is that these studies are all very old, and in fact, some of them are extremely old. So in terms of the treatment protocols that the individuals in these studies would have had, they probably don't bear a lot of relation to modern surgical and medical practice. These are also all observational studies. These are not randomized trials. But when you look in the meta-analysis, there was an associated reduction in risk of death or disease progression or recurrence of 27% associated with TSH suppression. But I would emphasize again, these are not high quality studies. In terms of how low to go with TSH suppression, these are observational data from a large study over a median of 6 years follow-up in 11 North American centers. And the graphs going A, B, C, D, E that you'll see here relate to stage 1, stage 2, stage 3, stage 4, and distant metastatic disease. And what you can see is that compared in all stages, compared with a TSH that is in the normal range or indeed elevated, people with an undetectable or a TSH that is below the lower limit of normal do better compared to those with a normal or a high TSH. But you'll see that there's really no difference between those with an undetectable TSH, so in this study below 0.1, or a TSH that's between 0.1 and the lower end of the normal range. So on the basis of this, absolutely full suppression would not seem to be beneficial. But I would emphasize again, these are observational data. There is a randomized control trial of TSH suppression, which came from a group in Japan who randomized 433 people with DTC to TSH suppression. And in this study, it was below 0.01 or to no TSH suppression. People with who are older, who had microcarcinomas, who had distant metastatic disease were excluded. The surgical management, I think, was I would say, more conservative than might be seen certainly in UK practice. So, for example, total thyroidectomy was only performed in people who had bilateral cervical nodal disease, or if they had disease in both lobes. And no individuals, even people with lateral nodal disease, received radioactive iodine treatment. So again, with this trial, I'm not sure how extrapolable it is to practice in other centers. But again, in this study, no benefit of TSH suppression was found. And just again to go through the graphs, graph A were patients, all patients. Graph B were patients with low-risk disease, and graph C were patients with high-risk disease. So you can see whether or not you had TSH suppression in this study made no difference at all to disease-free survival. Now, there is a downside to TSH suppression. These are data from the general population. So this is not cancer. These are not people with thyroid cancer. These are people with subclinical hyperthyroidism and what I call endogenous subclinical hyperthyroidism. They've got low-level Graves' disease, or they've got a toxic nodule that's causing a low TSH, but T4 and T3 in the normal range. And you can see that for people who have low TSH, and that would be undetectable, the risk of atrial fibrillation progressively increases with time, certainly compared to TSH that is low but detectable. Now, just as a caveat, what I call endogenous subclinical hyperthyroidism, Graves' toxic nodule, is not necessarily the same as exogenous subclinical hyperthyroidism. That is when we give levothyroxine in a supraphysiological dose to suppress TSH. And what I mean by that is that people who have endogenous subclinical hyperthyroidism have a low TSH because they are making higher levels of T4 and T3 in their thyroid gland that feeds back to suppress TSH. Whereas obviously in exogenous, we're only giving levothyroxine, or we're usually only giving levothyroxine. So the T3 levels are not elevated. And in fact, often the T3 levels are at the lower end of the normal range. And so particularly when looking at bone health, when looking at risk of atrial fibrillation, we tend to extrapolate from studies in endogenous subclinical hyperthyroidism, but they may not be directly relatable to people with thyroid cancer. But if you look at cardiovascular mortality in people with differentiated thyroid cancer, overall mortality, this is from data from a Swedish cohort study, overall cardiovascular mortality is no different from that seen in the normal population. But if you just look down the table to the, if you just go down to the part of the table which deals with atrial fibrillation, you'll see that the risk of atrial fibrillation is increased 1.36-fold in people with who've had thyroid cancer. And I suspect a significant portion of those did have TSH suppression, and that may have been the underlying mechanism. In this study, overall, 1.6% of people died from a complication of atrial fibrillation over 27 years, a maximum of 27 years follow-up. In this same study, they looked at the risk factors for death from atrial fibrillation. And it tended to be that the risk was highest in people who were diagnosed with thyroid cancer in the youngest age group, so 45 to 54 in this study. And it was also people who had had the longest duration of follow-up. Now, again, you might think that it's possible that they had been on TSH suppression longer. These are mortality data from a cohort study from Finland, again in people with differentiated thyroid cancer compared with controls. Overall mortality was no different, but cardiovascular mortality in the patients with thyroid cancer actually was slightly reduced overall. But if you looked at the prevalence of cardiovascular disease and the incidence of arrhythmias and atrial fibrillation, it was higher in the patients compared with the controls. And overall, in this cohort, 13% of patients developed atrial fibrillation compared to 11% of controls. And if you and in this Finnish study, they also found that there was a relationship between cardiovascular morbidity, not mortality, cardiovascular morbidity, and the TSH level. So patients with TSH below 0.1 did worse than those who had a TSH between 0.1 and 0.5. There was actually slightly less good outcomes, surprisingly, in those with a TSH above 0.5, which they didn't really explain very well. It wasn't statistically significant, but that obviously may have been a power thing. Osteoporosis is also a known consequence of long-term subclinical hyperthyroidism. Again, these are studies looking at risk of osteoporotic fracture in people with subclinical hyperthyroidism. And overall, the hazard ratio for hip fracture is 1.36, and for any fracture is 1.28. And as you would probably not be surprised, it's postmenopausal women who have a TSH suppressed that are particularly increased risk. There are even studies that suggest that subclinical hyperthyroidism is associated with an increased risk of dementia. And of course, we know that people with thyroid cancer do, in general, if you look at quality of life studies, they generally have a poorer quality of life than in the general population. And we see symptoms of anxiety, depression, poor sleep quality that are consistently reported, symptoms of palpitation, restlessness, tremor, sweating. And of course, these could all relate in part to TSH suppression. Now, I highlighted at the beginning that we've really got a lack of good quality trial data, and Christine Bollert and I put together a feasibility proposal for a trial that we were going to call Tertian to look at the outcomes in TSH suppression or not in people with indeterminate response to thyroid cancer, indeterminate on dynamic risk stratification. And we really struggled to get this funded because you would need at least 1,000 people followed up for 10 years in order to meaningfully evaluate it. And you'll appreciate that's not the type of study that funding bodies are falling over to support. So we're going to be left with poor quality data. We've mentioned a few times NICE guidance, which were published at the end of last year in the UK. And the NICE guidance state that people with low-risk tumors that do not require radioactive iodine do not require TSH suppression in the long term. And TSH suppression is also not required in those with comorbidities that would mean that TSH suppression should be avoided. So who do we, whoops, sorry, I've gone to the wrong bit. Who is TSH suppression recommended in? So it's recommended for, let me just put this back on slide view. There we go. TSH suppression is obviously recommended for those people who are more likely to get radioiodine ablation, and that's people with T3, T4 tumors, N1, those with adverse pathological features and with metastatic disease. And our guidelines recommend that the TSH should be kept below 0.01 for 9 to 12 months. And then, of course, there should be a formal process of dynamic risk stratification. And at that point, those who have an excellent response, so no structural disease, thyroglobulin less than 0.1, can be maintained indefinitely with a TSH in the 0.2 to 2.0 range, so detectable, but in the lower half of the normal range. For those who have an indeterminate response, so thyroglobulin detectable below 1, antibodies or indeterminate structural disease, then the recommendation is that TSH should be kept between 0.1 and 0.5. The guidance is a little bit unclear on the duration of that, and some guidance internationally says 5 years, some says 10 years. And for those who have had an incomplete response, those with non-structural residual disease and or thyroglobulin over 1, then the TSH should be kept below 0.01. So in summary, TSH suppression does have a sound physiological basis, but the extent and duration, the degree of TSH suppression and its duration should be stratified according to treatment response. I think TSH suppression is not an entirely benign treatment option. It probably does increase the risk of atrial fibrillation and may increase the risk of other long-term toxicities, particularly around bone health. Saba mentioned the iron trial of radioiodine versus no radioiodine for lower risk thyroid cancers. And that is likely to lead to a change in our practice around radioactive iodine. In the iron trial, patients did still get TSH suppression. So if you were strictly following the iron trial protocol, it shouldn't really, the results of that trial, affect our decisions around TSH suppression. But I think it will, because we're inevitably going to be giving less radioactive iodine. And so I suspect we'll be doing less TSH suppression. Thank you very much indeed for your time.